Welcome to the deep dive. Today we're getting into a really important topic, hemothorax. Something you definitely need to understand, especially when things need assessing quickly.
Yeah, absolutely.
Yeah,
We're talking about what happens when blood collects inside the chest cavity where it really shouldn't be.
exactly. And the plan today is to give you a clear, hopefully memorable run-through using your revision notes as a base.
That's right. We'll cover it all, definition, causes, right through to how it's managed and potential problems down the line.
Think of it as your high-yield guide. Good for revision, good for just getting a solid grip on it. We'll pull out the key bits and make them stick, ready to jump in.
Let's do it. Okay, first up, the definition. Hemothorax, simply put, is blood collecting in the pleural cavity.
And the pleural cavity is that space between the lungs and the inside of the chest wall.
Precisely. Blood in that potential space.
Okay. And what usually causes this to happen? Is it mainly injury?
Yeah, the most frequent cause is definitely chest injury or trauma. That damage can make blood vessels bleed, either vessels in the lung itself or in the chest wall.
Right. And the worry is that this blood starts interfering with things.
Exactly. It takes up space, physically squashes the lung, and that impairs how well the lung can actually function. It makes it harder to breathe.
Okay, so it compromises breathing. And I guess if there's a lot of blood or it builds up fast, that's when it gets really dangerous.
That's what we call massive hemothorax.
Yeah.
And yes, that can absolutely be life-threatening. It needs urgent attention.
And treatment generally involves.
Well, for most cases, draining the blood with a chest tube is the way to go. But for those really severe, massive ones, surgery might be needed.
Got it. A simple memory aid then. Hemo for blood, thorax for chest. Blood in the chest. Okay, so let's dig into the causes, the etiology.
So as we said, trauma is number one. Think penetrating injuries, like a stab wound. These can sometimes look minor on the outside, but cause serious bleeding inside.
That's a crucial point. The external look can be deceptive.
Definitely. And then there's blunt force trauma, car crashes, big falls. The chest takes a major hit, even without an open wound.
Right, those are the classic trauma scenarios. Are there less common causes we should know about?
Yeah, a few others. Sometimes bleeding can happen after chest surgery, or less commonly, a blood vessel inside the chest might just rupture.
Okay.
Also, certain blood clotting disorders make bleeding more likely, and very rarely you get what's called spontaneous hemothorax bleeding without any obvious trigger.
Spontaneous, wow. Okay, so maybe a way to remember causes. Trauma and other troubles. Trauma's the main one, but surgery, dodgy vessels, clotting issues, they're the other troubles.
It works. Trauma and other troubles.
Now, risk factors. Are certain people more likely to end up with a hemothorax?
Well, logically, anyone doing things with a higher risk of chest trauma is more susceptible. Think contact sports, maybe certain jobs with higher injury rates.
Makes sense. Ties back to the trauma cause. What about underlying health stuff?
Yeah, that's important too. People with blood clotting disorders like hemophilia are at higher risk because any bleeding is harder to stop.
Right.
And also, patients taking anticoagulant medications, blood thinners. Even relatively minor bumps could potentially lead to significant bleeding into that pleural space for them.
Okay, so it's a mix of lifestyle, occupation, and underlying health. Good to keep in mind. Let's get into the mechanics then, the pathophysiology. What's actually going wrong inside?
Right, so pathophysiology. We know blood is accumulating in the pleural space. The key problem this causes is mechanical compression of the lung.
Like you said, squashing the lung.
Exactly. Imagine that blood pooling around the lung, pushing on it. The lung just can't expand properly when you try to breathe in.
And that directly impacts getting oxygen in.
Yes. Less expansion means less air gets in, less oxygen gets transferred to the blood. Simple mechanics, really.
And where's the blood actually coming from? Could be different places.
It could be. The bleeding might originate from the lung tissue itself, the parenchyma, or it could be from the big blood vessels running through the chest, or even from smaller vessels in the chest wall, like the intercostal arteries.
So, various potential sources for the bleed, and the ultimate risk if it's not dealt with.
The worst-case scenario is the lung completely collapses under the pressure. That leads to severe respiratory distress. Basically, the body can't get enough oxygen. It's a critical situation.
Okay, that sponge analogy really helps picture the compression and collapse. So someone comes in, chest pain, short of breath.
Yeah.
How do you figure out it's hemothorax and not something else that looks similar?
The differential diagnosis. Super important. You've got symptoms, but several conditions can cause similar ones, so you need to carefully rule things out.
Okay, what are the main contenders on that list? The differentials.
Well, top of the list might be pneumothorax. That's air in the pleural space instead of blood. Similar location, different problem.
Air versus blood, got it. What else?
Pleural effusion. That's fluid in the pleural space again, but it could be other types of fluid, not necessarily blood, like fluid from heart failure or infection.
Okay, so same space, but could be air or other fluids. What about things not directly in the pleural space?
You definitely need to consider things like pulmonary embolism, a clot in the lungs blood vessels, or cardiac causes, maybe a heart attack presenting with chest pain,
Right, heart and lung vessel issues.
and then infections like pneumonia, inflammation like pleuritis, inflammation of the pleura itself, even just musculoskeletal pain, pulled muscles or rib issues. And finally, something like ARDS, acute respiratory distress syndrome, which is more widespread lung inflammation.
Wow, that's a broad list. Any way to keep track of those differentials?
Maybe think not blood. It helps focus on what else it could be. N for air, pneumothorax. O for other fluid effusion. T for thrombosis, PE. B for, well, maybe think big vessels heart, cardiac. L for lungs, pneumonia. O for ouch, musculoskeletal. O again for inflammation, pleuritis. D for distress, ARDS. It's a bit forced maybe, but might help jog the memory.
Not blood. I like it. Covers the main categories. Okay, shifting gears slightly. How common is hemothorax? Thinking about the UK specifically.
Well, the incidence isn't fixed. It really varies. It depends heavily on local trauma rates. Big cities with more accidents or violence might see more cases than quieter rural areas.
Right. And focusing on the trauma-related ones, is there a typical patient profile?
Generally, yes. Trauma-related hemothorax tends to be more common in younger people. And statistically, it's seen more often in males.
And the thinking behind that is?
It likely links back to risk exposure. Younger males, statistically, might be involved in more activities associated with physical trauma, whether it's sports, certain jobs, or accidents.
Makes sense. Okay, back to the patient. What specific signs and symptoms, the clinical features, would make you strongly suspect hemothorax?
Okay, key things to look for. Chest pain is very common. Shortness of breath, what we call dyspnea, is another big one. You might also see them breathing very rapidly. That's tachypnea.
And if you examine them, what might you find?
Listening to the chest with a stethoscope, you'd likely hear decreased or even absent breath sounds over the affected side where the blood is. If you tap on the chest, percussion, it might sound dull instead of resonant over that area.
Okay. What about vital signs?
You'd definitely check oxygen saturation levels, which are likely to be low. And critically, if there's been a lot of blood loss,
Yes.
you might see signs of shock. That means low blood pressure, hypotension, a fast heart rate, tachycardia, maybe confusion or altered mental state.
Right, shock is a major red flag, so maybe a memory aid here. SOB and shock in a painful chest. Shortness of breath, signs of shock, plus the chest pain hits the main points.
Yeah, that works well. SOB and shock in a painful chest covers the urgency.
So you suspect it based on those features. What investigations confirm it?
Imaging is key. Usually you'd start with a chest x-ray. That can show the blood in the pleural space, give an idea of the amount, and also spot other injuries like broken ribs.
Okay, x-ray first. What else?
A CT scan of the chest gives much more detail. It's really good for seeing the extent of the hemothorax and assessing any other internal injuries, especially in trauma.
And blood tests. What are you looking for there?
Essential. You need a full blood count to see how much blood has gone lost, check clotting function, and crucially, get a blood type and cross-match done in case they need a transfusion.
So, imaging sees the fluid, blood tests tell you about the patient's state and transfusion needs. How do you get that definitive confirmation?
Well, the clinical picture, reduced breath sounds, dull percussion, instability in a trauma patient is highly suggestive. And ultrasound is actually very useful in emergencies. It's sensitive for finding fluid quickly at the bedside.
Right.
But the gold standard, the definitive test, is sampling the pleural fluid.
Right.
That's called thoracentesis. You put a needle in, draw off some fluid. If you test that fluid's hematocrit, the percentage of red blood cells, and it's at least half the patient's blood hematocrit, so 0.5 times, that confirms it's blood. That confirms hemothorax.
Got it. So imaging suggests it, fluid tap confirms it. Clear path. Okay, diagnosis confirmed. How do we manage it?
Right. Management. Priority number one is always try to address the underlying cause of the bleeding, if possible. But immediately, you need to stabilize the patient, manage their airway, breathing, circulation, and deal with any other injuries they have.
And getting the blood out. You mentioned chest drains.
Exactly. The main way to remove the blood is inserting a chest tube, or tube thoracostomy. This tube goes into the pleural space and allows the blood to drain out, which helps the lung re-expand. Getting the tube in the right place is important for effective drainage.
And blood transfusions, when do they come in?
They're needed if the patient has lost a significant amount of blood and is showing signs of shock or instability. Or if bleeding is clearly ongoing, surgery might be needed too, especially for that massive hemothorax we talked about.
Let's clarify massive hemothorax again. What's the threshold?
Generally is defined either by a large initial drainage when the chest tube goes in, usually over 1,500 milliliters straight away, or if the bleeding continues at a high rate through the drain, say more than 200 mils per hour for a few consecutive hours.
Okay, that's a lot of blood loss. How do you handle that immediate emergency?
It's an all-hands-on-deck situation. You need high-flow oxygen. Be careful with IV fluids, as too much can actually worsen bleeding by diluting clotting factors. The focus is on blood products, red blood cells, plasma, often in a balanced 1.1 ratio, and giving tranexamic acid to help reduce further bleeding.
And the definitive fix for massive hemothorax?
Surgery. You need to find the source of the bleeding and stop it. Often, VATS, video-assisted thoracoscopic surgery, is preferred. It's minimally invasive, uses cameras, but sometimes a full open thoracotomy is necessary if the bleeding is too difficult to control otherwise.
Okay. Beyond stopping the bleed and draining the blood, what else is important long-term?
Preventing complications is key. You want to avoid infection developing in the pleural space that's called empyema. You need to ensure all the blood drains to prevent clots forming in there, or scarring called fibrothorax, which can restrict the lung long-term.
Are there specific medications used?
Antibiotics are often given either to prevent infection or treat it if it develops. Using clot-busting drugs, fibrinolytics, inside the chest is sometimes considered for stubborn clots, but it's done very cautiously because of the risk of repleting.
Right, makes sense.
And just to reiterate, massive hemothorax is a true emergency. It can cause respiratory and circulatory collapse very quickly, so it needs rapid assessment, following trauma protocols like the primary survey, and getting the cardiothoracic surgical team involved early is vital. VATS is generally the go-to surgical approach if needed.
Really underscores the urgency there. Okay, looking ahead, what's the prognosis usually like after someone's had a hemothorax?
It really depends on a few things: how bad the initial injury was, how much blood was lost, how quickly they got effective treatment, and whether any complications pop up.
But overall, can people recover fully?
Yes, thankfully, the outlook is generally good. With prompt, appropriate treatment, most people can make a full recovery without lasting problems.
That's good to hear. What things might make the prognosis worse?
Complications are the main issue. If they develop an infection like empyema, if the bleeding keeps going and needs more interventions, or if there's significant damage to the lung tissue itself, that can definitely worsen the outlook and make recovery longer.
So follow-up is important.
Absolutely. Regular follow-up is needed to monitor healing, make sure the lung is fully re-expanded, and catch any late complications that might develop.
Right. And speaking of complications, let's just list the main ones clearly.
Okay, key complications to watch out for: infection in the pleural space, empyema; persistent bleeding needing more treatment; damage to the lung tissue itself; ongoing breathing problems; respiratory distress; and potentially, if the blood loss was severe or trauma extensive, organ dysfunction elsewhere in the body.
So definitely not just about the initial bleed itself, lots of potential follow-on issues.
Okay, well, this has been incredibly thorough, a proper deep dive. Can you maybe wrap up the absolute key takeaways for everyone listening?
Sure. So hemothorax, blood in the pleural space, usually caused by trauma, squashes the lung, causes breathing issues. Diagnosis relies on imaging, X-ray, CT, and is confirmed by checking the hematocrit of pleural fluid from a tap, thoracentesis. Management is about draining the blood, usually with a chest tube, supporting the patient, and sometimes surgery, especially for massive bleeds. Prognosis is mostly good with quick treatment, but watch out for complications like infection, empyema, or persistent bleeding.
And those mnemonics again.
Right. Hem-LA blood, thorax, chest. Causes, trauma and other troubles. Features, SOB and shock in a painful chest. Diagnosis, imaging suggests it. Fluid tap confirms it.
Fantastic. Those are really helpful hooks. It's so clear that spotting and managing hemothorax effectively, particularly in emergencies, is just vital. Couldn't agree more. And for anyone wanting to dig deeper or revise this further, remember to check out pastthemsra.com and freemisra.com for more resources.
Excellent. Thanks so much for breaking all that down. And thanks everyone for joining us on the deep dive. We'll catch you next time.